I want to talk to you today about something that I believe is one of the most important and most overlooked connections in medicine for people over 65. The connection between the blood pressure medication that millions of seniors take every single day and the gradual silent changes in the brain that those medications in certain circumstances can contribute to. Changes that look like aging. Changes that look like normal forgetfulness. But that in some cases may be something more. Something preventable. Something that deserves a conversation that most patients are never having with their doctors. I am Dr. Daniel Chen. And today I want to explain the specific blood pressure medications that carry the most significant cognitive concern for older adults. What is actually happening in the brain when blood pressure drops too low or too quickly, and what every person over 65 on blood pressure medication should know and should be asking about at their next appointment. Now, before we go any further, I need to say something very clearly. High blood pressure is itself one of the most significant known risk factors for dementia, particularly vascular dementia caused by damage to the blood vessels that supply the brain. So I am absolutely not here to tell you that blood pressure medication is causing dementia and that you should stop taking it. That would be dangerously wrong advice, and I would never give it. Uncontrolled high blood pressure does far more damage to the brain over time than any of the medication concerns I am about to describe. What I am here to tell you is something more nuanced and more important than a simple message of good medication or bad medication. I am here to tell you that the dose, the timing, the specific type, and particularly how aggressively blood pressure is being lowered in people over 65, matters enormously for brain health, and that certain medications in certain circumstances and in certain people are being associated in a growing body of research with cognitive changes that deserve clinical attention and informed conversation between patients and their doctors. So let us start with what the brain needs to function properly, because understanding this is what makes everything else make sense. Your brain, despite representing only about 2% of your total body weight, receives approximately 15 to 20% of your total cardiac output. Every single heartbeat sends a significant proportion of the blood your heart pumps directly to your brain, because the brain, unlike most other organs, cannot store energy. It runs entirely on a continuous and uninterrupted supply of glucose and oxygen delivered by blood flow every single second of every day and night. The brain has a system for protecting this supply even when blood pressure fluctuates. This system is called cerebral autoregulation. It is the ability of the blood vessels inside the brain to constrict or dilate in response to changes in blood pressure in order to maintain a constant blood flow to brain tissue regardless of what is happening to blood pressure elsewhere in the body. In a healthy younger adult, cerebral autoregulation works across a wide range of blood pressures, and the brain can maintain stable blood flow even when systolic blood pressure fluctuates considerably. The brain adjusts and blood flow remains stable. But after 65, this autoregulatory system becomes less effective, less responsive, and operates within a narrower range. The brain of an older adult is less able to compensate for drops in blood pressure, whether those drops occur during sleep when blood pressure naturally falls, on standing up suddenly, which is orthostatic hypotension that I have discussed in a previous video, or when blood pressure medication lowers pressure more aggressively than the aging brain can compensate for. When blood pressure falls below the lower limit of the brain's autoregulatory range, blood flow to brain tissue begins to drop. Brain cells that are acutely deprived of blood flow may not die immediately, but they do experience a state of reduced function. And chronic repeated episodes of reduced brain blood flow over months and years contribute to cumulative damage to the small vessels inside the brain and to the brain tissue itself. This kind of cumulative damage from repeated episodes of insufficient blood flow is called cerebrovascular ischemia, and it is one of the primary drivers of what doctors call vascular cognitive impairment and vascular dementia. Now let us talk about the specific medications that concern me most. And I want to be specific and clear about what the research shows and what it does not. The first medication class is anticholinergic blood pressure medications. Specifically older medications, including some older antihistamines used for blood pressure, and a class called centrally acting antihypertensives including methyldopa and clonidine. These medications work partly by affecting a neurotransmitter system in the brain called the cholinergic system. This is the same system that is critically important for memory, attention, and cognitive function, and the same system that is damaged in Alzheimer's disease. These medications have significant anticholinergic properties, meaning they block the activity of acetylcholine in the brain. And blocking acetylcholine activity has direct cognitive consequences, including impaired memory, slowed processing, and confusion. In older adults with already reduced cholinergic function due to normal aging, these effects are amplified significantly. The American Geriatric Society includes these medications on the Beers criteria list of medications that are potentially inappropriate for older adults, specifically because of their cognitive effects. If you are over 65 and you are taking methyldopa or clonidine for blood pressure, please ask your doctor whether there is a more appropriate modern alternative that controls blood pressure effectively without these central nervous system effects. The second medication class is beta blockers, specifically the older lipophilic beta blockers that cross the blood-brain barrier, including propranolol, metoprolol, and to a lesser extent atenolol. Beta blockers are a large and important class of medications with genuine benefits for heart failure, arrhythmia, and certain types of hypertension. I am not suggesting they are universally harmful, but the lipophilic beta blockers, those that dissolve in fat and therefore cross from the bloodstream into the brain, have been associated in several studies with cognitive side effects in older adults, including depression, sleep disturbances, nightmares, and in some cases memory impairment and slowed cognitive processing. The mechanism is thought to involve beta receptor blockade within the brain itself, affecting noradrenergic neurotransmission, which plays an important role in attention, arousal, and cognitive processing. The research in this area is not entirely consistent. Some studies show a cognitive effect, others do not, and the picture varies depending on the specific medication, the dose, the duration, and the individual patient. But the concern is real enough that if you are over 65 and taking a lipophilic beta blocker and you have noticed any changes in your sleep, your mood, your memory, or your cognitive sharpness since starting or increasing this medication, that is a conversation worth having with your doctor. The third concern, and the one I want to spend the most time on because it is the most clinically significant and the most relevant to the largest number of seniors over 65, is the issue of aggressive blood pressure lowering and what it does to the aging brain. There is a concept in geriatric medicine called the J-curve in the relationship between blood pressure and cognitive outcomes in older adults. The J-curve means this. As you might expect, very high blood pressure is associated with worse outcomes, including cognitive decline, stroke, and dementia. But contrary to what many people assume, blood pressure that is very aggressively lowered, particularly in older adults, is also associated with worse outcomes, including faster cognitive decline and increased risk of dementia in some populations studied. The J-shape of the risk curve means that there is an optimal range for blood pressure in older adults where outcomes are best, and that going too far in either direction, too high or too low, carries its own risks. This is particularly relevant for adults over 75, in whom blood pressure targets have been the subject of significant clinical debate. The SPRINT trial published in the New England Journal of Medicine found that intensive blood pressure control targeting a systolic below 120 reduced cardiovascular events compared to standard control targeting below 140. But subsequent analyses, including the SPRINTMIND trial, which looked specifically at cognitive outcomes, found that intensive blood pressure control was associated with a higher rate of serious adverse events, including episodes of hypotension, syncope, and acute kidney injury in older adults. And while the SPRINTMIND results were initially promising for cognitive protection with intensive control, the overall picture, when examined more carefully in the context of very old and frail adults, becomes considerably more nuanced. Multiple studies, including large European cohort studies looking at adults over 80, have found that very low blood pressure in this age group was associated with faster cognitive decline than moderately elevated blood pressure. This does not mean high blood pressure is good. It means that in very old adults, particularly those over 80, the relationship between blood pressure and brain health is more complex than simply lower is always better. and that aggressive lowering to targets appropriate for younger adults may in some cases in some patients do more harm than good. This is recognized in the clinical guidelines of major geriatric medicine societies, including the American Geriatric Society, which explicitly recommends that blood pressure treatment targets be individualized for older adults, particularly those over 80, based on overall health, frailty status, and risk of adverse effects, rather than simply applying the same targets used for younger patients. The fourth specific concern is about what happens to blood pressure during the night and its relationship to brain health. As I discussed in a previous video on nocturnal blood pressure dipping, the brain is particularly vulnerable to blood pressure changes during sleep. When blood pressure drops too far during the night, the brain's autoregulatory ability may be insufficient to maintain adequate perfusion, particularly in older adults with cerebrovascular disease. The evidence suggests that excessive nighttime blood pressure dipping, where blood pressure falls too far during sleep, is associated with white matter lesions in the brain, accelerated cognitive decline, and increased dementia risk in older adults with existing cerebrovascular disease or reduced cerebral autoregulation. This creates an important clinical question that most seniors are never asked. Is your blood pressure medication causing excessive drops during the night, below the level that your aging brain can adequately compensate for? The only way to know is through ambulatory blood pressure monitoring, the 24-hour blood pressure test I described in a previous video, which shows exactly what your blood pressure is doing during every hour of sleep. Now let me give you the practical information I want you to take from this video. First, ask your doctor what your specific blood pressure target is and why that specific target, for you, given your age, your overall health, your kidney function, and your cognitive history. This is not a standard question that most older adults ask, but it is an entirely reasonable one, and the answer may be different from what you expect. Second, ask whether any of your blood pressure medications have central nervous system effects, specifically whether any of them cross the blood-brain barrier, and whether there are alternatives with equivalent blood pressure control and a more favorable cognitive profile. If you are on methyldopa, clonidine, or a lipophilic beta blocker, and you have noticed any cognitive changes since starting it, this conversation is particularly important. Third, ask whether your blood pressure has ever been assessed during the night through ambulatory monitoring to ensure that nighttime values are not falling excessively, particularly if you are on medication taken at bedtime or if you have noticed morning confusion, morning headaches, or a feeling of being foggy in the early hours. Fourth, tell your doctor about any cognitive changes you have noticed since starting or changing any blood pressure medication. Memory that seems worse, processing that seems slower, confusion that seems new. These are worth reporting, not assumed to be just aging, because in some cases a medication adjustment is all that is needed to restore clarity that was being inadvertently suppressed. Fifth, if you are over 80 and your blood pressure has been aggressively lowered to targets below 120 systolic, make sure you are having an explicit conversation with your doctor about whether those targets are appropriate for your age, your frailty status, and your cognitive trajectory, given what the research on very old adults now shows. Let me bring everything together now. High blood pressure is a genuine and well-established risk factor for dementia, and managing it is critically important for brain health after 65. But the relationship between blood pressure medication and cognitive health in older adults is more nuanced than most standard appointments have time to explain. Anticholinergic blood pressure medications including methyldopa and clonidine directly affect the neurotransmitter system most critical for memory and are considered potentially inappropriate for adults over 65 by major geriatric guidelines. Lipophilic beta blockers, including propranolol and metoprolol, cross the blood-brain barrier and have been associated in some research with cognitive side effects in older adults. Aggressive blood pressure lowering, particularly in adults over 75 and 80, may in some cases reduce brain blood flow below the threshold that the aging brain can compensate for, contributing to cognitive decline rather than preventing it. And excessive nighttime blood pressure dipping from medication taken at bedtime may impair brain perfusion during sleep with cumulative consequences for brain health over time. The answer is not to stop blood pressure medication. The answer is to make sure that the medication, the dose, the target, and the monitoring are all appropriate for your specific age, your specific brain health history, and your specific risk profile. You deserve that level of individualized care. And now you have the knowledge to ask for it. I am Dr. Daniel Chen. If this video gave you information that you did not have before, please share it with someone over 65 who takes blood pressure medication every day and has never had this conversation with their doctor. Subscribe to this channel for weekly videos made with genuine care for older adults who deserve real information about their own health. And leave me a comment below telling me which blood pressure medication you are currently taking and whether you have noticed any cognitive or memory changes since you started it. I read every single comment, and I genuinely look forward to hearing from you. Take care of your brain. It is the most important organ you have, and it deserves the most careful and most individualized medical attention you can give it.